that, I will pass over to Akriti.
Great, thank you, Sita. And welcome everyone to the second meeting of the Child Health Task Force Nutrition Subgroup. My name is Akriti Singh and I co-chair this subgroup with my colleague, Dr. Bridget Adam, who will be facilitating the Q&A section. And the topic for this meeting is caring for small and nutritionally at-risk infants and their mothers, MAMI Care Pathway, experiences from Ethiopia and Colombia. We will have 3 presentations today. The first will provide an overview of MAMI Care Pathway, and the following 2 will share implementation experiences. And now to introduce our speakers. Our first speaker is Dr. Marco Kerak. Marco is a clinical associate professor and program director for the Nutrition for Global Health, MSc, at the London School of Hygiene and Tropical Medicine. Initially trained in pediatrics, he did a PhD on severe malnutrition based in Malawi before finishing specialty training in public health in London. He's been working on MAMI since 2008 when he was lead researcher on the original MAMI project. He currently co-leads the MAMI Global Network and is chief investigator on a cluster randomized controlled trial of the MAMI approach in Ethiopia, working in partnership with ENN, Goal Ethiopia, and Jimma University. Our second speaker is Leah Asefa. Leah is a senior nutrition research officer focusing on MAMI in Goal Global based in Ethiopia. She has a bachelor's in public health, master's degree in project management, and is currently pursuing a master's degree in reproductive health. She has around 5 years of experience in nutrition and research. Our third and final presenter will be Andrea Garcia Charnachart. Andrea currently coordinates the nutrition component in emergencies at Save the Children Colombia. She has a BSc in nutrition and food sciences and a master's degree in genetic, environmental, and nutritional factors of growth and development. She's a specialist in health promotion and breastfeeding counseling. And now I will hand it over to Marco for the first presentation.
Fantastic. Thank you very much to you and to all colleagues at the Child Health Task Force. So let me just start my slideshow and share screens. Got to get the right setup. Fantastic. So can everybody see now?
Yes, we can, Marco.
Fantastic. So thank you very, very much again for this opportunity to present on the MAMI Care Pathway. And I'll be starting off giving an overview of what the care pathway is and how it works. And to begin with, I want to say a big, big thanks, firstly to our generous funders, to the Eleanor Crook Foundation, who funded this, and Irish Aid, who funded the care pathway development, and Eleanor Crook also her funding some of our wider work in this sphere. So huge thanks for making it possible. And also big thanks to many, many partners, collaborators, and I'm sure many on the call today who've contributed in lots of ways and spent a lot of time either with this version of the care pathway, with previous versions of the care pathway. And particular thanks to Marie McGrath, Eleanor, and colleagues at the Emergency Nutrition Network, who we've worked together on this for many years, since 2008. So big thanks to everybody and to you, our audience, for joining to hear more today. So our vision for MAMI is that every small and nutritionally at-risk infant under 6 months and their mother is supported to survive and thrive. And so we're after building strong infants, strong mothers, and strong futures, and really thinking about building bridges towards 2030, the Sustainable Development Goals target. So who does MAMI target? Who's our target population? The target population is small and nutritionally at-risk infants under 6 months and their mothers, who are key to this whole thinking and to the whole philosophy underlying MAMI. I want to just go over some case definitions of what do we mean by small and nutritionally at risk. The first thing to acknowledge is that the details of this are still evolving. So the World Health Organization is currently updating their guidelines for severe malnutrition. And so some of the nuances about how we define this patient group are in progress, are evolving. But what is clear is that there are 2 different aspects to it. Firstly, there are anthropometric case definitions, and secondly, there are some clinical case definitions, clinical factors to also consider. Focusing on the anthropometry, two aspects of that. There are infants who are born small, so who have a low birth weight, either because of in utero growth retardation or prematurity. And again, we know just by being small, by being born with a low birth weight, the risk of subsequent mortality, morbidity is high. Another way to identify them is by anthropometric measures. So particularly underweight. So there's really strong and growing evidence that underweight is a key indicator for identifying risk. Wasting is still there in some current guidelines, and so we acknowledge wasting, but there's also increasing data, increasing evidence for low MUAC, even for infants under 6 months. But again, the details of that, the exact thresholds and exactly how we use that is still being reviewed, and there should be a lot more on that over the coming year. There are also dynamic measures. So we're thinking also about infants who are failing to grow, so growth faltering, growth failure, those who are dropping across their centiles and not keeping up with their growth. So that's the anthropometry. But it's really important to also consider case definitions. So rather than wait till infants become very vulnerable, until they lose lots of weight, we're also very conscious that we need to be flagging issues early. So things like if there's a breastfeeding problem that's severe, they may not yet have dipped below these anthropometric case definitions, but they're at risk. And so we need to be identifying and supporting them. And another common factor that is prominent in the MAMI care pathway is maternal health, and particularly maternal mental health. And there's growing lots of evidence that maternal mental health has big impact on infant nutrition. So we're trying to identify any issues there early so as to support. But whatever the details, it is clear that the numbers involved are large. So this is an analysis of 54 countries we did recently for a WHO meeting. And if we look at the various indicators, so 20% of infants overall in these 54 low middle income countries were underweight, of whom 8% were severe. Low birth weight also very common, almost 18%, low birth weight, and wasting also common. So all of these indicators, whatever the details, it's a prevalent problem. And I just want to flag also that many of these indicators coexist and overlap. And that's one of the reasons why there's lots of current work into understanding the implications of those overlaps. So that's WHO, small and nutritionally risk infants under 6 months. Why do we care about them? Why do they matter? They matter because we want to ensure that they survive and thrive. The short-term risks of being small and nutritionally at risk are mortality and morbidity. But they're also really important medium-term risks, and these are not so widely measured, but increasingly acknowledged and really important for us as a child health and nutrition community to think about. So there are implications for impaired development, and consequently implications for educational attainment, and even strong and growing evidence about long-term implications like a heightened risk of non-communicable disease for those who have early life nutritional adversity. And this matters across the life cycle. We're all familiar with the first 1,000 days, that critical window of opportunity, but there's also a critical gap in the first 6 months. So the neonatal community or the antenatal community are doing lots for antenatal care. There's also lots of work being done after the first 6 months in CMAM programs, other nutrition support. There's lots of great work being done in neonatal care in the first month or so of life. But the rest of those first 6 months can be a real gap in many settings. And so why we're doing this, we're trying to optimize those early life opportunities and create life cycle, but also intergenerational benefits. How are we supposed to do this? The core principle is assessing and supporting infants and their mothers at every community and health service contact. So I've mentioned there are lots of contacts during antenatal care, during the antenatal period. So the in utero growth is really critical. And at the moment, we're not doing lots in that period because lots of other groups are addressing that. But that's the thing that will grow in future. And those are links which we want to make as time goes on. But there are many other contact points that already happen at the moment. So birth weight is increasingly being recorded. Most settings have a very high immunization coverage. So there's lots of contact points at 6 weeks, 10 weeks, 14 weeks, when the great majority of infants are coming for immunizations. And also at the same time points, infants are coming for growth monitoring visits. As well as those routine visits, there are also lots of contacts when infants come for minor illnesses, for diarrhea, for pneumonia, for fever. And it's really important to make the most out of those contact points. And so whenever they come, to make sure they're assessed, and if found to be at risk, appropriately supported. And finally, in the community. So again, lots of community contact points. And MAMI is about making the most out of any of those. So how does it fit into the wider healthcare system? So this is from a WHO booklet thinking about tertiary level healthcare, secondary and primary, and community level. The main MAMI work at present fits in early postnatal period and also in the first 6 weeks to 6 months. So at tertiary level, if an infant's born small, vulnerable, that's an infant who we can support, who we can do lots for. Similarly, at secondary and primary care level, they can be identified and supported. And at community level, so again, that's a great opportunity to identify in programs like growth monitoring programs, like IYCF programs. So all those other contact points are an opportunity to consider whether there's a heightened risk and to enroll in a MAMI program. But also, we are thinking about identifying infants at an earlier stage. So if it's a multiple pregnancy, the risks are that much higher. So there's opportunities to identify and to make links with those MAMI services, even in the antenatal period, rather than suddenly be surprised that there's a risk, that there's an issue later on. So there are lots of opportunities to link more closely, both in tertiary level care and community level care with higher risk pregnancies as things develop. Our guiding principles are that we bridge intervention services and perspectives, that we're based on an integrated care pathway approach, and that we build on what's already existing in terms of nutritional, clinical, and other services. So in terms of bridging, it is about nutrition, that's our core, but it's also about clinical services and social interventions. It's about focusing on the infant, but also the mother or the carer. It's about operationalizing the 2013 severe malnutrition guidelines and linking also with IMCI. And you know what, one thing that we see for the future of MAMI is to be a future module within IMCI. And it also bridges developmental and emergency humanitarian settings. We take a care pathway approach because it's the process and the planning and the participation that all really matter. And we build on what's already there because it's really important to build synergies, create links, and make the most out of those existing services. So how does the pathway work? There are two main phases. There's screening, and then there's treatment in the main programs. And so at any contact point, like we said, immunization, like growth monitoring, like a routine under 5 visit, we expect a very quick assessment. And for most infants, for 80, 90%, they'd be fine. So no issue is identified, and they can just be referred into normal care, routine care services. So things like IYCF. If a potential issue is identified at screening, then they're referred for a more detailed, a more in-depth assessment. And this would be by somebody who has slightly higher level expertise, more training. And at this point, they'd be classified into 3 situations. So potentially, they might be low risk and can be referred back into the routine healthcare and IYCF counseling. They might be high risk, and so they need referral into an inpatient, a specialist setting. Or they are at risk, but they can be safely treated in an outpatient, in a community setting. And so those are the 3 levels. So this one is separate to MAMI, but that's really the foundation. And of course, some infants may develop problems, may develop issues while in routine healthcare, and they can be referred in. but we're particularly focused on those who are sick and those who are at risk but stable. So those are the ones that we follow up, and we follow them up over the first 6 months of life. And at the 6 months of age, we have a review, and hopefully most are recovered then. But if they're still small, if they're vulnerable, if they have ongoing clinical problems, either they or their mother can be referred for ongoing care. So what's involved? So again, in summary, it's that rapid screen, and then the full assessment involves a few steps. So number one, just considering the IMCI danger signs. Secondly, anthropometry and growth assessment. Thirdly, thinking about the breastfeeding and the feeding, any issues there. C is for clinical issues, either in the mother or the infant, and thinking about what may be underlying the problem here. So is it infection? Is it disability? Is it some other disease rather than a breastfeeding problem? And we're also considering social or other issues. And then depending on what's identified at that full assessment, that shapes the details of support. So if they're complicated, so i.e. they're sick, they're not feeding, they're unstable, they go into inpatient care. And clearly the focus there is on their immediate clinical problem. But also MAMI specific support can start even while they're in inpatient settings. So things like feeding support, things like supporting the mother, her health, her mental health. So support can start in the inpatient setting. The bulk of infants, which is why we have this thicker arrow, are going to be clinically stable. So they're feeding okay, even though they're at risk, and they can be treated safely in outpatient care. So again, very much following the principles of CMAM for older children. And this has two elements. So depending on the issues identified, we want to focus on those and address those. So in some infants, it may be a simple feeding issue, a simple breastfeeding attachment issue. In others, it may be maternal undernutrition or maybe maternal mental health, which is the principal thing needing support. So there's tailored support. But there's also core topics, and these are relevant to all infants and mothers presenting. And so these are covered at subsequent visits. So the first thing we want to think about is relaxation therapy. We want to do that at every visit. And that's because there's a growing evidence base that relaxation has, apart from the mental health and well-being benefits for the carer, it also has direct effects on the breast milk, increased supply, so better infant growth, decreased cortisol in the breast milk. So very direct benefits of relaxation therapy. Other things which are common problems, which are often ignored and not addressed, things like crying and sleep, things like early childhood development. We want to ensure good father, family, community support and spend a session talking about what's going on there. Is there anything we can do to support that and to address any issues or concerns coming up? We want to address family planning and also complementary feeding. So those are core topics running through which everybody will benefit from, and then referral as needed and monitoring as needed. So this is the website. So just hot off the press today. So just launched. So you can have a look at the user guides, all the materials that are there, and you can download them. And in summary, what's there are user guides, there are forms, and there are also counseling cards and support action booklets. And just to show you one of those. So this is the enrollment and follow-up form. So this is where this is free to use, free to download, free to photocopy. So you'd register the basic details up at the top. And then at each visit, you'd monitor the clinical progress, the growth and the nutritional status. So monitoring the weight and how that's changing over time. You'd monitor and ask about the feeding at every visit and ask about maternal health and maternal mental health at every visit. And then on the flip side of that card, you note the date of the visit and any specific advice or actions taken or given. And then here is a reminder of those key topics, the core topics running through to discuss with all carers. And there's advice, there's reminders about what kind of decisions and how to implement, how to act. And basically, if the problem's getting better, then you'd reduce the frequency of visits. If it's about the same, you'd carry on with either weekly visits or fortnightly visits. And if a problem is getting worse, if things are not settling, an infant may need referral. And you've got a whole suite of counseling cards and materials to help with various things that can come up. So here's one about how to deal with and advise if the underlying issue is sore nipples, cracked nipples. And here's an advice card about crying and sleeping. And so the other key principles aligned with this are that it's simple to follow, and it recognizes that supervision and referrals can be limited, and so it gives healthcare workers simple how-to guides. We want to subtract from the clinical and patient workload, and that's why we're focusing a lot more on weight for age and MUAC, on those simpler, quicker measures, rather than weight for length. It's another reason why, rather than spend time with every single mother infant coming through, the vast majority of whom are absolutely fine, we're focusing just on those who really have the highest needs, who need support, would benefit from that. And it's also why we're providing these forms, which are brief, easy to fill in, and form the basis of future audit. So trying to make things easy. We're also trying to build synergies with other services. So things like relaxation therapy, help with mental health, well-being. And above all, we want this to be satisfying both to healthcare workers as well as to patients. And from earlier research in Bangladesh, and lots of really great stories about how very simple use, very simple interventions really can make a difference. And as well as making a very big difference to the carer, also very satisfying to the healthcare worker dealing with that. So how do we adopt it? So what are the next steps? So a few key things. It's always key to engage with and get buy-in from local staff, teams, and managers. And there are different levels of adaptations in different settings. And so in some settings, we hope that tools can be adopted more or less as is, potentially with just translation. In other settings, there may be minor adaptations. In other settings, potentially more major adaptations are needed. So it's about figuring out what's needed, what's appropriate in your setting. And above all, whatever you do, please do share with us in the MAMI Global Network so that others can learn from your experience. So last few slides. So it's still at an early stage, we're still evolving. So it's an evolution that we want, not yet a revolution. So we do want rollout, but this is at the stage where we do also need further testing and evidence. And key questions include things like what's the optimal enrollment criteria and effectiveness and efficacy. And I'm sure lots of you are aware of this, but there's a great resource on the Emergency Nutrition Network website where you can share your experiences and also ask questions about the care pathway. So just quickly about how does this fit with other key things? So the WHO Severe Malnutrition Guidelines 2013, so they focus on wasted infants. They do cover inpatient as well as community-based care, but they focus really on the nutritional problems rather than these wider aspects. National CMAM guidelines, so we've reviewed those recently, and the vast majority only really focus on inpatient care for vulnerable infants. They don't cover outpatient care. IYCF is mainly community-focused, mainly on nutrition, a little bit, but really not much on clinical problems. And these wider problems, again, it varies from guideline to guideline, but not a big focus. And in contrast, on the other side, on the health side of things, the IMCI, the hospital care, they focus on weight for age, weight for length. They do cover some community-based care and some nutritional problems, but not in a lot of depth. And early child development focuses on a very specific area. And what the MAMI care pathway does, it bridges those gaps and brings in all of those elements together in one coherent whole. So in summary, and to finish, so we want strong infants, strong mothers, and we want to build bridges to 2030. We want to be linking not just to focus on infant, but also considering the mother, the family, and wider society. MAMI is about bridging hospital care and community care. It's about focusing not just on weight gain and weight-based outcomes, but also on functional outcomes on health and well-being, on nutrition and health disability. And it's also linking the developmental and humanitarian settings. And whilst our focus has been very much on low middle income countries, also lots of relevance to high income settings. So that's it. So big thank you all for visiting, and do please check out our website to find out more. And also just recently launched a Twitter account and a YouTube channel where I hope that materials will be gathered. I hope that lots of cases that will come up in these discussions will also be hosted in future. So thank you very much.
Thank you, Marco. And our next presenter will be Leah Asefa.
Okay, thank you. So I'm Leah. I will present the MAMI experience in Gambella. So before directly diving into MAMI program, I want to give you a highlight on GOL's nutrition program in Gambella and how it started. So in 2030, there was an outbreak of civil war in South Sudan, and thousands of South Sudan refugees poured over the border into refugee camps around Gambella, which leads to the opening of 7 refugee camps. So please move to the first slide. Thank you. So in 2040, in response to the large influx of refugees from South Sudan, GOL in collaboration with UNHCR and ARA began to implementing nutrition programs as the lead agency in 2 newly established refugee camps. They are namely Takidi and Kule camps, and these 2 camps are currently hosting more than 100,000 refugees, where 65% of the population are children. And currently we are providing the programs of BSFP, TSFP, OTP, IYCF, SC, and also MAMI. Next slide, please. So where we were before 2060 and in between 2040 to 2060, after the initiation of the nutrition programs in 2050, GOL noted high number of infants in the camps, and observers suspected cases of malnutrition in infants attending weekly basic feed distributions with their mothers. So in response to this, and also in the introduction of the 2030 updated WHOSAM guidance, GOL Ethiopia broadened its nutrition approach to include extremely vulnerable infants under 6 months for malnutrition prevention, identification, and management by integrating it into the existing nutrition, mother-to-mother support group, and also weekly contact points in blanket supplementary feeding programs. So as there were no well-structured guiding materials to support the health workers, the focus were only on identifying infant needs, and emphasis were not given to the maternal factors, and case identifications were only carried out using the weight for length screening, and support were provided based on the identified infant needs. So in the absence of MOAC-based case identification for infants under 6 months, it creates a screening challenging, and it was very challenging, and an increased acute malnutrition prevalence at 4 and 5 months of age was observed, likely contributing to the child burden of acute malnutrition. So later on, in early 2060, the first version 1 MAMI tool was introduced and trialed in the 2 refugee camps in Gambella, which helped GOL to provide a more systematic outpatient counseling, and it filled the gap in clinical care for outpatient MAMI management, and also started to assess and address maternal issues. Next slide, please. So in general, the key steps that we follow in MAMI are community case identification, risk assessment for enrollment, and counseling and support. In the case identification, we use a specially designed MARC measurement tabs that are MAMI marks to support early case identification. So this is a reversible tape, and one side is used to identify infants less than 6 months, and the other is used for older children 6 to 59 months and pregnant and lactating women. Furthermore, there are 2 versions of this mark. One is enumerated for the health workers, and while the other is non-enumerated, just displaying colors that inform actions for the mothers. And in addition to stage screening, where community outreach agents undertake monthly mark screening in the community and refer those identified at risk to the second stage of screening, which involves reassessment at the facility level. And once they identify mother-infant pairs as at risk of malnutrition, they will refer them to the MAMI centers. And in the MAMI centers, anthropometry, clinical danger signs, breastfeeding, and mental health assessments will be conducted for the mother and infant pair. Support will be provided on infant and maternal feeding and psychological counseling during the weekly visit to our MAMI sites. Following several weeks of visits, it found to be no longer be considered at risk, the pair is discharged. However, we do follow the infants for the next 12 months on the first, second, 6 and 12 months to make sure they're doing well and to reinforce the positive feeding message. So starting from the stage of enrollment until the last post-discharge follow-up, we will use digital data gathering using ComCare and analytical dashboards to enable us to track real-time patient process. So what we need to note here is that if they found to have any complications in between, the pair is referred to inpatient care for more intensive care. Next slide, please. So several innovations have been made in delivering the MAMI approach, and one is the breastfeeding educational video for mothers developed by Global Health Media that had been translated to newer language for use in the MAMI and IYSAFE programs with the aim of improving beneficiary engagement and behavior change. Newer language is the local language of the South Sudan refugees. And the videos were downloaded onto tablets and are shown based on mother's breastfeeding challenges or preference. By that, counselors decide the sequence of the videos, and the videos will be repeated if required. On average, each video lasts 7 to 8 minutes and were shown on a one-to-one basis. The outcome of the exposure were also assessed, and both the health workers and the beneficiaries had a positive feedbacks, and these are some of the responses we get from the assessment from the mother sides. They like how the videos were. They like it being able to practice the behavior while watching the videos and found them easy to follow and remembered much more. So from the health worker side, they say the videos were comprehensive and saved them valuable time, not only with delivering the counseling, but also save time convincing mothers to participate. So next slide, please. So as we know, every program come up with a challenge and an opportunity. Despite that, progresses will also be made. To start with the progress we came so far. So one is there is an increased awareness of acute malnutrition in infants in the camp by both staff and refugees. The interventions has identified infant feeding trends that were previously not well understood, and early identification of at-risk cases of acute malnutrition in infants under 6 months has reduced the number of some cases with complication which presented at 6 months. As ways of teaching mechanisms also enhanced, extensive community practice on infant care has also improved. So in terms of challenges faced, one is that workload on IYSAFE counselors, because we are using our IYSAFE counselors to implement the MAMI program, which is an additional task, and we are not also providing an additional resources. And the MAMI guideline by itself is lengthy and taking 20 to 40 minutes, which in turn also affects the attendance of the beneficiaries, since the MAMI program requires weekly visits and it might take up to half a day max. So, and it gets more difficult if the mother have older children that attend the program, such as BSFP, OTP, or TSFP, and there is also a lack of trained female nurses who speak the newer language. The second one is digital data collection support. As I have said earlier, we are using digital data collection, and it supports us more time. It supports us, and it's more timely. It improves data quality by reducing missing and invalid data entries. Though the refugee camps being residing in poor receptions areas, data synchronization is made by the end of the week, and some data may not be fully updated. In addition, data may not be filled on time by the counselors due to the over workload that they have. And the other one is high defaulter rate, and the refugees are mobile, are not stable. Some of them move to another camp, and some of them move back to their home country while they are still in the program, which makes it even harder to trust them. And given that this is a largely a dependent population, and other programs such as BSFP, OTP, TSFP have food provisions the beneficiaries tend to expect provision of tangible items despite their knowledge and clear explanation by the counselors that the program is support alone project. And another one is that some staff challenged with measuring maternal anxiety and depression, and on the top of that, referral links are not accessible. In terms of opportunities, having an existing nutrition structure under one roof have made it easy for referrals and also long-term follow-up of cases to build evidence and know what works best and not. With the high interest of MAMI, we have given a workshop on March for implementing partners in Gambela refugee camps that are non-governmental organization, which is an added value to address so many infants as much as possible because we are only implementing on 2 refugee camps. We also form a MAMI interest group to share experience, progress, and also improve integrations. And lastly, the WHO updated guideline is expected to be released on 2022, which we think is an opportunity to have a broader insight. Next slide, please. So these are some of the added values and learnings we came to know through the process. To start with the added values, as MAMI services are provided through outpatient facilities, they are easily accessible and usable. And the MAMI also holds both prevention as well as treatment of malnutrition at early stage. And MAMI uses more than just anthropometry to help identify infant at risk, feeding assessment, clinical assessments, and assessment of maternal mental health are also taken in account to ensure infants' well-being. So by recognizing that the infant's well-being is dependent on the mother's ability to care, the package of support addresses the infant and mother pair. In terms of our learnings, we now know that mothers can use reversible MAMI mock tests to identify both infants and older children at risk of malnutrition with high degree of accuracy, and the program has the potential to address maternal needs as that of the infants, as infants are entirely depend on the food and care they receive from their mothers. And in place of discharging infants, once they are no longer classified as at risk, we continue with the escalated follow-up until they reach 6 months. And finally, we have come to realize that the quality of counseling and modes used are playing a significant role in determining potential outcomes. So this is my presentation. Thank you.
Thank you, Leah. Our next presenter is Andrea. Sorry, Andrea, I think you're on mute.
Thank you. Sorry. Good morning. My name is Andrea Garcia. I work with Save the Children Colombia as Nutrition and Food Security Coordinator. Next slide, please. I want to thank you for your attendance today to this event, where I want to share with you the experience of the implementation of MAMI in Colombia. MAMI in Colombia started in November 2020, and we plan to go at least until August 2021. Currently, MAMI in Colombia uses the PASS tool and name, and I wanted you to know that although the Spanish translation does not match the acronym of MAMI, we decided to keep it because of its meaning in Spanish, mother in diminutive. Next slide, please. To begin with, I am going to talk a little bit about a part of the context of Colombia at this moment. Save the Children is responding to the Venezuelan migration crisis in a humanitarian context in different regions of Colombia. 1.7 million Venezuelans are currently living in Colombia, more than half of them in an irregular way, which means that they do not have documentation to live in Colombia, which means, among other things, that they do not have access to health services, except for the emergencies. One of the latest needs assessments conducted in December 2020 provides us with relevant information, such as that 44% within the households surveyed are between 0 and 18 years of age. Of these, 13% are children under 2 years of age, and in this group of children under 2 years, 22% are children under 6 months of age. The departments with the highest proportion of households with pregnant and or lactating women are Antioquia, Santander, and La Guajira, each with 31%. Save the Children implements MAMI in La Guajira. Next slide, please. At the national level, the exclusive breastfeeding rate is at 36.1%, according to the last National Nutrition Survey of 2015. And in the 2020 needs assessment, it was found that only 51% of migrants or refugees give exclusive breastfeeding to babies under 6 months. 80% of the respondents are not affiliated to the health system, as I mentioned previously, associated to the lack of regular status in the country. In this assessment, it has also been found that exclusive breastfeeding decreases as the baby grows, passing from 91% in the first 20 days of life to 36% at 5 months of age. And a specific fact about the territory where we work with MAMI is that according to the epidemiological report of La Guajira, between January and March 2021, 102 cases of lower weight were reported. Next slide, please. Save the Children responds to the migratory crisis from different sectors and territories. In La Guajira, through the food security component, we have activities for the promotion, protection, and support of good IYCF practices. And in the health component, we have a sexual and reproductive health unit that offers prenatal control, mental health services, case management with emphasis on GBV, and postnatal follow-up until the 2 months of life of the babies. IYCF activities have been operating since November 2018 and health activities since April 2019. Before MAMI, they had already complemented each other through the building of a breastfeeding corner and an individual consultation room where the nutrition team carried out its activities. However, after some time of establishment of both components, questions began to arise from both teams. From IYCF, what else can we do if in IYCF activities we detect a baby that needs more help? And from health, what happens with the follow-up for babies after 2 months of age? Fortunately, we received a call to review if we could implement MAMI. And after some work and brainstorming, we were able to see how we could integrate this component, which, although it is not a medical checkup, allow us to follow up babies who are over 2 months old and who have some nutritional risk that doctors cannot solve and that doesn't need hospitalization. And in the other hand, it receives children who are located by IYCF staff and who need constant follow-up to continue growing. The MAMI staff shares the individual consultation room at the breastfeeding corner with the IYCF staff in the Save the Children health unit. And it is integrated between these two components. Next slide, please. MAMI staff receives referrals from the newborn first checkups and from the food security sector. And in the MAMI first assessment, we have also made referrals of the mothers to the mental health component. As we are close to food security, we can also refer to them if mother needs it. Because of COVID-19, the flow of people in the Save the Children health unit is low. So the MAMI staff also has articulated with the child protection sector to organize meetings in human settlements to share the objective of MAMI component and organize assessment meetings on field. The MAMI staff also has articulation with national health units of the territory where small newborns receive attention. After this hospital discharge the patients, they make the referral of mothers and babies to the MAMI staff. In the classification of mother and baby, if the classification of mother and babies are without risk, they are referred to the IYCF team. If they are at risk, they are enrolled in MAMI component. And thanks to the articulation that the Save the Children health unit have with the local hospital, if needed, the MAMI staff can refer immediately to the emergency department of the hospital. Next slide, please. We have tried to follow the MAMI pathway, but we have had to make adaptations because some challenges. Transport and COVID-19. How we solve it? With the transport, the challenge is that the Save the Children health unit is located far from where people live. So we had to decide to mix a follow-up call one weekend and a face-to-face appointment the other, interleaving this methodology until the baby and her mother are in the best condition to stop the follow-ups with the MAMI staff. With COVID-19, people is scared of going outside their homes, and we can't receive a lot of people in the health unit. So as mentioned before, and taking advantage of the meetings we organize with the community and in the community to show them the component, we are also organizing MAMI assessments in human settlements where people live. Next slide, please. Our conclusions. The first one is that MAMI gives the chance to mothers and babies to receive support and connect with other services. Then explaining and offering the service to communities and other sectors can ensure support to mothers and babies. The other is that MAMI is useful to support migrants and ethnic populations. And MAMI is the support that mothers and babies need in that phase of life where everything may be new. Next slide, please. Thank you very much for your attention. We are going back with Akrit.
Thank you. I'm actually going to hand it over to Bridget for the Q&A. Thank you so much for the presentations.
Thank you very much, Marco, Leah, and Andrea, for your work and presentations. It's great to see how the MAMI care pathway comprehensively covers the critical gaps in care for children less than 6 months, starting at the prenatal stage. That's fantastic. Question for Marco. You shared a slide about the differences between MAMI care pathway and different existing care for children under 6 months, namely IMCI, CMAM, IYCF, community-based programming that already have some guidelines. What will be your advice to practitioners in integrating these into other existing services? What are the most essential elements that need to be taken care of?
Yeah, no, that's a great question. Thanks very much. So I think that the key thing is to just assess what's there, because that varies a huge amount in different districts. And so I think that for me, the best way to think about MAMI, it's like a bridging, it's like a signposting service. So it's about bringing together those different elements into one coherent whole to deal with an issue. And that's why we call it a care pathway, because it's really focused on the process. And so in the longer term, we would love the MAMI care pathway to be a module within IMCI, which pulls in that wider focus on nutrition, which really highlights the importance of maternal health, maternal mental health, and infant growth, health, and well-being. So yeah, it's really about thinking what's there, how is it functioning, and especially what's happening at the front line. Because I think one thing that's very clear is that there are lots of guidelines in lots of settings which live very beautifully up on people's bookshelves, but are never really translated into frontline practice. And so MAMI is really thinking about what does happen on the front line of clinical care and how can we make the most of these visits. And maybe just one example of that we know that in many settings, growth monitoring is strongly supported, and that's a central plank of many people's interventions. But you also know there's lots of evidence that growth monitoring doesn't work very well. And part of that reason is because it's one thing to monitor growth, but then if you find somebody whose growth is faltering, who's struggling with growth, then it's what do you do? And so we believe that MAMI provides that missing piece of the jigsaw. So it's the what do you do when an issue is identified. And we believe it adds value to other services. So rather than infants coming, say, just for their immunizations, they will also get linked into wider treatment services. Or another example is in many clinics, and I know this from going around, you look at registers and you can see that infants are coming in with diarrhea, with pneumonia, and their weight's been recorded, it's been measured, and it's quite small, but nothing is really done about it. They just get their acute problem dealt with and nothing else happens. And again, MAMI provides that piece of the jigsaw where we're saying, okay, look, we're going to actually do something with this measurement that we're taking. And if it's small, if the infant is therefore at risk, there are all these other links, there are services that we can provide, and there's other things that we can do to benefit that mother and that infant, and hopefully to prevent them coming back again with more severe advanced disease. Bridget, you're just on mute. I'm not sure if there were any other questions related to that.
Yes, thank you. Sorry, I was speaking.
Sorry.
I was on mute. There's a question from Tima that would like to hear about the interventions targeted to mothers with potential postpartum depression or other mental health issues. How do you avoid stigma in these cases? And then where there is no maternal mental health services available, what would you advise? Can MAMI not be implemented?
Yeah, that's a great question. And I remember with regards to mental health, always being very inspired by my good friend and colleague, Rob Stewart, who's also on this call. And Rob's a perinatal psychiatrist. And he very rightly pointed out that if you approach things like, let's talk about your mental health, then there can be a real stigma. Then people can push back and get a bit nervous. And I think what MAMI does is open some doors into just changing the phrasing. It's saying, let's talk about how we can support you to support your infant. And that, I think, changes the dynamics. It still provides the same kind of support. And I think just talking, just having somebody listen to what a mother's concerns are, having somebody listen to what support is a father, is a wider family having or not having, as is sadly sometimes the case. I think just having those conversations can make a big difference. The relaxation therapy contributes towards that, but it's also about knowing what are the local services and being able to feed into those and make the best use of those. So I put in the chat, for example, things like friendship benches, which is a great intervention, which has been evidence-based and found to be effective in different settings. And again, these days, thankfully, Rob and many others are pioneering mental health services in all countries, that they are available for those with more severe, with clinical depression, anxiety, those with suicidal intent who need specific and expert care. So again, it's about doing some basics, building the foundations, but also about providing those referral pathways to the real expert services.
That's great. Thank you so much. That's helpful, and it's great to see how it extends into the communities with the friendship bench and other existing family support programs. One other question, there's been a lot of questions regarding anthropometric indicators and its uses and all that. There's a question from Heather to ask if gestational ages plays a role in either identifying at-risk children less than 6 months or interventions and services that are provided. Over.
Yeah, again, that's a really great question, and I'm sure others, apart from her, think probably getting at the existence of things like the intergrowth standards, where we can take into account the gestational age. I think that's an important future question. At present, the reality is that most settings won't know what the gestational age is, so we just need to go with the weight and the unadjusted weight for age. And certainly some data suggests that adjusting doesn't make a big difference in identifying higher risk, and just even the unadjusted birth weight, the unadjusted weight for age, etc. If it's preterm, that will still come up, and that those infants will still be identified, and will be identified even more so by the current indicators. But I think, that's a great question, and that's one of the things that WHO and others are really thinking carefully about what's the added benefit of adding those nuances into the anthropometric assessment, because clearly it takes time, it takes more expertise, it takes more training, but does it add significant extra value in identifying high risk? And also in being able to say to others that, okay, you may be small, but you're small because of prematurity, so therefore we don't need to treat in the same way. So So open question, but I think one thing to emphasize is that MAMI is primarily, what we're describing here is primarily a behavioral intervention. So it actually doesn't matter that much. We can afford to be sensitive. We can afford to have a fairly flexible, inclusive enrollment criteria, because we're not proposing, certainly for this element, for giving medications, for giving other treatments. It is a different question if you're talking about antibiotics or giving supplements, then it would be much more important. But what we've just presented now is the foundational, the behavioral elements, which translates some of those cores into practice.
Okay, great. Thank you. One last question because of time, and for others, most of the questions have been answered in the chat box, including availability of the training materials and all that. So please refer to the chat box, and we would also send information about where you can get the materials and others as a follow-on. One last question to our two other presenters, either Leah or Andrea. It's a question for Manjari. How long does assessment and counseling take? How do the HCP manage to fit it into their busy schedules? We all know how busy normally this counseling takes, and that has been always a bottleneck. So if there's no dedicated HCP, how can we fully integrate it into routine care?
So, okay, yeah, here. So I have seen, like I have discussed earlier, one of the challenges that we are facing is the IYSF counselors' workload. So going through the full MAMI guideline, it takes 20 to 40 minutes maximum. So what we are doing so far is, from the new initiative that we took using the global health media, it's one way of reducing their workloads, because when they show the mothers the global health medias, it's mostly the videos are related to breastfeeding. So when they see the videos, they will go through the other tasks that they have in the IYSF and also MAMI. So that way that we are reducing their workloads.
Okay, thank you very much. Because of time, we are going to answer more of the questions and send it around, and there'll be a link for you to be able to access the questions and previous slides and all that. So I'm going to call on Andrew Cunningham, who's an SBC specialist with USAID Advancing Nutrition, to speak about an upcoming webinar where they'll be sharing new resources for IYCF programming. If you worked on any IYCF programming guideline development, you know that you need some illustrations and so on. So Andrew is going to share with us an upcoming webinar where they'll be sharing an updated image bank. Over to you, Andrew.
Yes, thank you, Bridget, for allowing me a bit of time to share information about our webinar. So USAID Advanced Nutrition has partnered with UNICEF to relaunch the IYCF Digital Image Bank. The bank was designed to make high-quality illustrations available for nutrition programs to use and adapt in IYCF programming. And the updated image bank follows the original version you might be familiar with, which was done by UNICEF and USAID's Spring project. The latest version aims to expand its repertoire of images for use in programming in a way that programs are integrating IYCF into other related areas, including responsive care and overweight and obesity. Next week's webinar will highlight what's possible in ART and SBC communication when leveraging image bank resources. You'll learn about the features of the image bank, as well as recent and current uses of the image bank for COVID-19 and nurturing care programs and materials. So even if you're familiar with the bank, there's new content that may interest you. And of course, you'll also learn how to get in touch with us to contribute your IYCF images to the bank if you so choose. So you can find a link to the webinar and register at the address on the screen here. And I've just added a link again in the chat. So please share with your IYCF, SBC, and communication colleagues and networks, as well as any artists that you know that you've worked with for IYCF related materials. Thank you very much.
Thank you very much, Andrew, and all our presenters. This brings us to the end and the top of the hour. Thanks all for your contributions. Stay tuned for materials that will be shared by Sida, and connect with us. Thanks. Bye.
Great.